Hello everyone, welcome to another session of next Saviours Essential Question Series, NEET PG 2025. Today we are going to have a discussion on blood transfusion complication reactions. Particularly our focus would be on TRALI and TACO. As you know, that recently they are asking the questions out of this topic very frequently. So starting with the question, a 45-year-old male with a history of cirrhosis due to chronic hepatitis B is admitted for upper GI bleed. His hemoglobin is 6.8 gram per deciliter, which becomes an indication for blood transfusion, and he is transfused with 2 units of packed RBCs. Now, approximately 3 hours after the transfusion, he develops acute respiratory distress with severe dyspnea, tachypnea, and hypoxia. On examination, he has bilateral crackles on auscultation, but no jugular venous distension, no lower limb edema, and a blood pressure of 110 by 70 millimeters of Hg. Chest X-ray shows bilateral fluffy alveolar infiltrates without any cardiomegaly. Which of the following is the most likely diagnosis? So basically, what they are asking is the complications related to the transfusion of the blood, and what basically are the complications related to the blood transfusion, which could be categorized into two. The complications can be categorized into two. The first one is the immediate complication that happens within 24 hours of blood transfusion, and the other set is delayed complications, which take 24 hours to week for its appearances. Now, although there is further classification into immune and non-immune mediated, but as far as questions are concerned, you have to restrict yourself in identifying the immediate and the delayed complications. So among the immediate complication, the first one is the acute hemolytic reaction. As the name indicates, it is because of the ABO incompatibility leading to intravascular hemolysis. So how will it be identified? Fever, chills, hemoglobinuria, back pain, hypotension, renal failure, and DIC in severe cases. What is the management? Immediately you have to stop the blood transfusion. You have to start with the IV fluids, diuretics in case of renal failure, vasopressors for shock, and the supportive care. One of the most common blood transfusion reaction is the febrile non-hemolytic transfusion reaction, which is because of the cytokine release from the leukocytes in the stored blood. And what are the clinical features? Fever, chills, mild dyspnea, but there is no hemolysis. And what is the management? You have to slow or stop the transfusion and give antipyretics in the form of acetaminophen. Now, for future transfusions, try to go for leukocyte reduced blood so that there is no cytokine mediated immune reaction in the form of febrile non-hemolytic blood transfusion reactions. Another one is the allergic reactions, as you know, which is identified as urticaria, pruritus, flushing, mild dyspnea, which could be because of the IgE mediated reaction to the plasma proteins, and antihistamines, corticosteroids if the blood transfusion reaction is severe, and transfusion can be continued if it is mild. Anaphylaxis is a severe IgE mediated reaction. You already know about this, which results in sudden hypotension, bronchospasm, angioedema, and even shock. So immediately you have to stop the transfusion. Intramuscular epinephrines, IV fluids, oxygen, antihistamines, and corticosteroids as a supportive method to be given for these cases. So these are all immediate blood transfusion reactions, but most importantly, we have to focus on these two, that is TRALI and TACO, that is transfusion related acute lung injury and transfusion associated circulatory overload. Basically, what happens in case of TRALI is that it is anti-leukocyte antibodies in the donor plasma that results in non-cardiogenic pulmonary edema. While in case of TACO, what happens? It is a rapid transfusion volume which increases leading to fluid overload. So these are the basic mechanisms behind both of them. And how are they different from each other is based on the diagnostic criteria. In 2019, there was a revised consensus definition of the diagnostic criteria for TRALI, which included the onset of the features within the 6 hours of the transfusion. And those features are bilateral pulmonary infiltrates on the chest X-ray, no evidence of circulatory overload, and hypoxemia, that is decreased saturation count. Other than this, there will be a partial pressure of the oxygen to FiO2 ratio of less than 300 millimeters of Hg and the oxygen saturation of less than 90. And there is no other identifiable cause for the respiratory distress syndrome. So this is the diagnostic criteria for TRALI. On the other hand, what is TACO? As we have already identified that TACO basically is the transfusion associated circulatory overload. So the basic pathophysiological mechanism is that if there is a rapid transfusion volume, then it will result in the fluid overload, and that fluid overload might result in the acute respiratory distress. There may be positive fluid balance, that means more than 10% increase in the body weight or evidence of fluid overload. There will be elevated the BNP of more than 100 picogram per milliliter is confirmatory. Then elevated CVP, which is evidence of increased venous return on the cardiac preload. Radiographic evidence of the pulmonary edema, the chest-text ratio, pulmonary congestion, cardiomegaly, and pleural effusions, as we are going to talk about later, and the cardiovascular changes in the form of hypertension, tachycardia, and JVP distension. So you see, in 2018, the International Society of Blood Transfusion, that is ISBT, gave the diagnostic criteria for the TACO, which is the diagnosis of the TACO requires acute onset within 12 hours of transfusion and at least three of the following six criteria. So, if three of the following six clinical features are present, then the diagnosis of TACO is made. Now, if you go back to the table, there are other immediate transfusion reactions also. There could be a bacterial contamination, which is leading to sepsis, which is because of the contaminated blood products, particularly the platelets, which is evident as high fever, chills, hypotension, septic shock, and the management is stop the transfusion, continue the IV broad spectrum antibiotics, the fluid resuscitation, or vasopressors if at all required. Hypocalcemia is one such complication which you have to be aware of, because the citrates which are present in the stored blood, it binds with the calcium in the parent blood. So as a result of which, what happens? There will be a hypocalcemia. So in order to correct this hypocalcemia, you have to give IV calcium gluconate if at all the condition is symptomatic. But it has to be given slowly. Now, this is important, but because it has to be given extremely slowly. And the clinical features are perioral tingling, muscle cramps, the tetany because of hypokalemia. Hyperkalemia, why does it happen? Because the potassium leaks from the stored RBCs, particularly in the old blood unit. So it might result in arrhythmia, the muscle weakness, and the management for hyperkalemia. Another one is the hypothermia, which is cold blood transfusion leading to decreased core body temperatures with the shivering, arrhythmia in the severe cases. And what all you have to do is start with the warm blood. That's it. So these are the immediate complications of the blood transfusion. Particularly, our focus was on TRALI and TACO. And when we are going to have a discussion on the question that we have framed in the beginning, then some of the differences in between the two are going to be emphasized over. Next, coming on to the delayed complications or the late complications, as you know, which appears after 24 hours of blood administration. So these are delayed hemolytic transfusion reaction, which is because of the minor antigen mismatch leading to extravascular hemolysis. Then post transfusion purpura, which could be because of the allo antibodies against the platelet antigens leading to severe thrombocytopenia. Then iron overload, which is associated with a chronic transfusion syndrome where there is repeated transfusion, as we have witnessed in case of thalassemia or sickle cell disease. Then graft versus host disease. It is rare, but it is fatal. The transfused donor lymphocytes, they attack the recipient lymphocytes, particularly in the immunocompromised patients. So it will result in pancytopenia, fever, rash, and liver dysfunction. And finally, the transmission of the infections late, like bloodborne pathogens, like HBV, HCV, HIV, syphilis, cytomegalovirus. So it will be the clinical features are going to be variable based upon the parent infection. Now, reading the question might make some sense. We already have talked about that the patient was admitted with the upper GI bleed and the blood transfusions were done. Now, approximately 3 hours after the transfusion. This is point number one, which is important for you to remember because in case of TRALI, we have seen less than 6 hours. It happens. He developed acute respiratory distress with severe dyspnea, tachypnea, and hypoxia. So this is point number two, which is mentioned in the question as an important clinical feature. If you further read the question, that on examination he has bilateral crackles on auscultation, but no jugular venous distension, no lower limb edema, and a blood pressure of 110 to 70 millimeters of Hg. That means almost normal blood pressure, but there is no jugular venous distension. Now, the X-rays shows a bilateral fluffy alveolar infiltrates without cardiomegaly. This is point number third. So his BNP is within normal limits. Echocardiography reveals a normal ejection fraction without evidence of left ventricular dysfunction. What is the most likely diagnosis? So if you go with a step-by-step approach to the question, then you will find that TRALI is particularly the answer for this question. Why? Point number one, because of the acute onset of the respiratory distress. TRALI typically occurs within 6 hours of blood transfusion, most commonly within 1 to 2 hours. And the patient in this case developed symptoms which is 3 hours after the transfusion. Next, what are the key clinical signs? Bilateral crackles on auscultation, which is suggestive of the pulmonary edema, which happens in case of TRALI. Then hypoxia, which is SpO2 of 85%, suggestive of the severe respiratory distress. That also happens in case of TRALI. Now, no signs of fluid overload, like there is no JVP elevation, no peripheral edema, normal blood pressure. Now, this helps differentiate TRALI from TACO, which presents with the fluid overload, as it is the basic pathophysiological mechanism behind TACO. If you look at the chest x-rays, in case of TRALI, there will be bilateral fluffy alveolar infiltrates without any cardiomegaly. So it is classic for non-cardiogenic pulmonary edema, which is hallmark of the TRALI. On the other hand, in case of TACO, there will be a cardiomegaly, although it is not there in this case, but there will be pleural effusions. And along with this, there could be a vascular congestion, the severe vascular congestion that could be evident on the chest x-rays. And finally, the supporting laboratory findings in the form of normal BNP, the absence of fever or hypotension. So all these are responsible for ruling the other options out. If we go back to the question, then what are the options which are provided? One is TRALI, other one is TACO, then the respiratory distress syndrome and the anaphylaxis reaction. So if we look out at the differences in between, now TRALI, as you know, that it occurs within 6 hours, it was mentioned in the question, and most probably you have made the answer for that particular one. The blood pressure is relatively normal, JVP used to be normal, and the bilateral infiltrates are there in case of TRALI. In TACO, we have already talked about, it happens within 6 to 12 hours, hypertension due to volume overload. The JVP is found to be elevated, pulmonary congestion, cardiomegaly, and pleural effusion is seen in case of X-rays. What in case of adult respiratory distress syndrome? Variable. The timing of onset would be variable because it is the inflammatory response to the infection or systemic insult, and because in this case it is related to the sepsis. Now, the blood pressures, it could be variable, may have hypotension in case of septic ARDs. The jugular venous pressure is normal. The chest x-ray show infiltrates, diffuse infiltrates. Other symptoms would also be provided to you, like fever, because it is a case of the sepsis. So fever, the signs of infections, or the respiratory failure. But these are not provided to you in this question. And finally, the anaphylactic reaction. It is IgE-mediated hypersensitivity, which appears minutes after transfusion, and the blood pressure is always low, while the JVP might remain normal or low. The BNP levels are normal, but as far as X-rays are concerned, there are no infiltrates. The bronchospasm is more common. And the other features would have been provided to you in the question had there been a question asked in relation to anaphylactic reactions are the presence of urticaria, the angioedema, or the bronchospasm. So what all is presented to you in this question is the timing, that is 3 hour post transfusion, absence of cardiogenic signs, bilateral pulmonary infiltrates, normal BNP strongly favor TRALI. TACO is ruled out due to the absence of fluid overload signs. That means there is no JVV elevation, no peripheral edema, normal BNP. Sepsis is ruled out because there is no infection source mentioned in the question, and or there is no systemic sign of the sepsis mentioned in the question. Anaphylaxis is ruled out as there are no signs of allergic reaction, there is no urticaria, no bronchospasm, and no hypotension. So hope you'd be able to mark the answer related to these sort of the questions, particularly the complications of the blood transfusions. We have tried to make it more difficult, although the questions asked are relatively severe. They are asking about the managements in particular. All the best for your future examinations. In order not to miss any update, please join our Telegram group. The link is provided to you in the description. Thank you.